everybody to the second international webinar on minimally invasive extracorporeal technologies. And continuing with the theme of yesterday, we're discussing various aspects of minimal extracorporeal circulation. And this morning the focus will be on anesthetic considerations. And so the first presenter is Dr. Baryshnikova, who will be talking about patient blood management in cardiac surgery. Good morning, Dr. Baryshnikova.
Good morning, everyone. I'm now starting my presentation. Okay. Can you see my presentation?
Yes, please. Go on.
Okay. So, good morning, everyone. I'm here on behalf of Dr. Marco Ranucci, that's my chief. I'm a biologist running the coagulation and hemostasis lab at the cardiac surgery operation block in San Donato Hospital. So today my lecture will be about the principles of the patient blood management in cardiac surgery, and I hope that our consideration of the topic will be useful for your daily practice. So when talking about cardiac surgery and coagulation, basically we are talking about a very specific model, and no matter how complicated are the alterations caused by the surgery and the extracorporeal circuit, at the end we know that there are definite conditions that we are able to assess and then modify in order to optimize the outcome of our patients. Without going into the detail, I would like to stress the fact that in most situations, we are working with a timing that allows us a comprehensive evaluation of the patients. And essentially, I'm talking about point of care monitoring. And this setting gives us minutes, 10 minutes, 20 minutes, if not seconds, for a reasoned and weighted decision making that at this point cannot be empirical. And patient blood management in cardiac surgery is not just management of postoperative bleeding, but lies on three very important pillars, from preoperative evaluation to possible postoperative treatment of bleeding. All these stages have their own importance, and each of them could potentially compromise the safety of the patient, the efficacy of the surgery, and the overall outcome. And every point of these pillars is modifiable, so we can and we must direct our efforts towards optimizing their management. I would like to draw your attention to the fact that anemia is included in all these three pillars. And this is because the red blood cells are fundamental for oxygen delivery, of course, but considered also from the coagulation point of view. Erythrocytes are the biggest cells in the bloodstream and normally keep platelets close to the vessel walls, where they are called to their aggregation duties when required, and that is when there is a lesion in the vessel wall. In case of anemia, be it pre-existing or induced by hemodilution, for example, the lower number of circulating erythrocytes allow platelets to circulate far from the vessel wall, making all the coagulation cascade reactions slower to be triggered and more difficult to initiate. This, for me, it's very important to keep in mind at every stage of patient's pathway through the hospital stay. So the first pillar of the preoperative management of the patient, preoperative means that patient can be admitted to the hospital a couple of weeks or a couple of days before surgery, and usually we can do a lot about that because the local specifics and protocols of the hospital. And depending on that, we are called to do our best to make the patients face surgery in their best shape. And this includes the management of anemia and the management of concomitant therapies. So most of the times patients arrive to us with some kind of therapy on board, and we can have antiplatelet drugs and anticoagulation drugs, and sometimes we have both. For antiplatelet drugs like clopidogrel, ticlopidine, prasugrel, ticagrelor, point-of-care devices for platelet punching could help us a lot in defining the optimal timing of the surgery. And this time could be much shorter than 5-7 days reported in the guidelines. There are patients that are fully resistant or that are partial responders to the drugs, and patients who have a very rapid thrombopoiesis and build a whole new platelet populations in a few days instead of a week or so. And all of them will certainly benefit from the reduction of the pre-surgery hospital stay. And the hospital will be happy too about that. And the same concept applies to those patients who require a couple of more days of recovery from antiplatelet drugs that indicate, because reducing their bleeding risk, waiting a couple of more days for sure counterbalance the costs and the risks of the prolonged hospital stay. Is about the anti-classical and anticoagulation drugs. This management is more or less established, usually based on INR for the vitamin K antagonist, but a particular attention should be paid to the direct oral anticoagulants that are now very used in the daily practice of the cardiologists. And more and more patients present to the hospital with renal dysfunction. And in this case, the true washout period of the drug is very difficult to predict. And the residual substance should be dosed with appropriate methods. And the same applies for fondaparinux. This means that every hospital, every central labs of the hospital should have appropriate kits to dose into drugs, because otherwise it's very difficult to manage these drugs. Of course, in case of emergent or urgent surgery, this anticoagulation can be rescued, must be rescued by PCCs, by antidotes in case of docs. And new antidotes are coming in a few years, I think. And it's really important to optimize coagulation of this patient before surgery. The anemia correction is a really measured pillar of this preoperative evaluation, and really this topic deserves a lecture of its own for its importance. But just let me say that the preoperative hematocrit of less than 34% represents an independent risk factor for mortality. So it's usually recommended to correct this value, even when in the operation room, before when the patient is entering the operation room, or before entering to the extracorporeal circulation. And values of hematocrit between 30 and 34, it's usually up to our anesthesiologists and local protocols. And of course, in this case, when you are correcting anemia in the operation room, consider it also from the coagulation point of view, as I've said before. The intraoperative pillar of the patient blood management considers a number of factors that minimal invasive extracorporeal circuit already help minimizing. And nevertheless, this is an example from our institution of what should be considered and ideally included in an established protocol to be implemented and always, and not occasionally, used by all the perfusionists and all the anesthesiologists. For example, including antithrombin 3 dosing in the preoperative panel of blood exams of all the patient and supplementing it in case of deficiency before entering in extracorporeal circulation has been a major step forward in optimizing heparin dosing in our institution. And now it's always done. At the end comes the last pillar, the one of the perioperative and postoperative management of bleeding. That is my specialty at the end of the surgery. And signs of possible excessive bleeding should be recognized as soon as possible, just observing the surgical field or the first amounts of blood in the chest drainage. And point of care monitoring, this is an example of a basic algorithm we are using in our institution. Point of care monitoring could be prompted by a suspicion or an impression, but it's not correct to use it in advance. And when an abnormal point of care test is an evidence of an excessive bleeding there to come. So wait for the bleeding and then measure and not treat numbers. That is the philosophy of our hemostasis and coagulation lab. Patients showing a manifest and evident excessive bleeding must not leave the operation room until establishing the cause of bleeding. So being it a coagulopathy to be corrected or a surgical reason. This is because if at the end of the measuring, you establish that the reason of bleeding is probably surgical, so the patient needs additional surgical hemostasis, being still in the operating room minimizes the risks of a re-exploration. And that risks are significant, increases the mortality and more postoperative morbidity risks really significantly. And you can find a number of different protocols and algorithms in the literature, and in my opinion, absolutely correct that this is happening, because every institution should set its own protocol based on both on the evidence available in the literature for numbers and procedures, and on the availability of different point of care devices, of drugs like fibrinogen, like PCCs, like FIBA, and so. And last but not least, cost and easiness to get blood products. For example, for us, it's very difficult to get blood products because we don't have a blood bank inside the hospital. So we are really keen on applying this protocol and to use the substitutional products like fibrinogen and PCCs. And considered all these factors, it's logical that every hospital will develop its own protocol. And apart from the availability of resources, a protocol for bleeding management should follow a logic that relies on the basics of the coagulation science.
Dr. Baryshnikova, thank you very much so far. I wonder if we could just summarize. Unfortunately, we have a very, very tight time schedule.
Yeah, I think it's my last slide.
Thank you so much.
Okay. This means that even we have multiple abnormalities at our first point of care assessment after surgery, our intervention should be a step-by-step sequence and treatments administered step-by-step. And one drug at a time, then we observe the effects and eventually retest and recorrect with the same drug with a different drug. And for instance, residual heparin should be always the first to be corrected, because neutralizing excessive heparin will immediately boost thrombin generation and without it adding any other factor. And thrombin generation requires fibrinogen and platelets, so we can administer drugs that boost thrombin generation without having normal levels of fibrinogen platelets. And my last consideration is that the impairment of the coagulation after surgery is only a temporary condition. And what we need to do is to help our patients to achieve a minimal sufficient coagulation, just not to lose too much blood in the first hours after surgery. Because after that time, his organism will replace all the factors by himself. And thrombosis is just the other face of the medal of the coagulation, staying very close to bleeding. And over-treating patients with pro-hemostatic products expose them at risks that are as great as those of excessive bleeding. And I'm done with the presentation. Thank you for your attention.
Good. Thank you so very much for that overview. I think we'll carry on now, just in the interest of time, with the next topic, which will be Dr.